The Lawton Instrumental Activities of Daily Living Scale measures independent living skills in the following domains: telephone use, shopping, food preparation, housekeeping, laundry, transportation, medication management, financial management. This video presents a case example of how the scale is used.
So this patient came in yesterday, 72-year-old female admitted to the hospital from home with shortness of breath and heart failure exacerbation. And she was found in the lobby by her apartment manager, confused and unable to catch her breath, and the manager called 911. She is widowed for 10 years and lives alone in her apartment where she has resided for 30 years. She has 2 children. One is in New York and the other one is 2 hours away from her. So she does all her activities alone. And she is oriented to self, date of birth, city, but not date or time. Okay. Mrs. Johnson's, in addition to taking your blood pressure, listening to your lungs and heart, I have some more questions to ask you. This will actually help us plan your care here in the hospital when you have recovered and when you go home.
Well, I'll try, but I'm really tired and I think I can take care of myself. My son and daughter can help me when I need it, and my neighbor helps me get food. And I want to go home.
Just do the best you can. And then if you get tired, I'm going to stop and I'll let you rest.
All right.
Okay? Okay. Just letting you know that I have a list of questions here. And I'll be jotting down notes, like putting your answers. Okay? I'm going to tell my students to sit down with me so they could observe.
All right. I think I'm all right. I want to go home.
I know you want to go home. That's why we're trying our best to help you go home right away. Okay?
All right.
Okay. Let's start. Do you have help with anything at home? Like any chores or like cleaning your house?
No, I can take care of myself.
Do you have telephone in your apartment?
Yes, I do. My son or daughter calls sometimes, and I answer it if it rings, but I don't get very many calls.
Do you call anyone? Let's take, for example, make an appointment to see your doctor.
No, I can't remember the last time I saw the doctor, but my neighbor might help me.
What if you needed someone? Like if you want to call someone, what would you do if you don't know the number?
Well, I guess my daughter could help me.
Okay. Let's talk about shopping. How do you get your groceries?
I go to the 7-Eleven. I have a cart so I can carry milk and frozen foods and so on.
Let's talk about a full week's of groceries. Or let's talk about bigger things like go shopping for your clothes. How do you do that?
I get it all at the same store. I'm very tired.
Okay.
Very tired.
We'll let you rest, okay? And we'll come back later to ask you more questions. I know you're tired.
Yes, I am. I'm very tired.
Because of the patient's fatigue and anxiety, the nurse decides to end the assessment and allows her to rest. She also discusses her concerns about the challenges presented during the assessment with the clinical nurse specialist.
I have some concerns about my patient. She came from ER, and I admitted her.
Together, they decide that this would be a good opportunity for the clinical nurse specialist to model techniques to allay the patient's anxiety and engage the patient in helping to identify ways to meet her unique needs and maximize her independence.
Mrs. Johnson, I'm the clinical nurse specialist, Carla, and I take care of the older patients in the hospital. And I wanted to come in and meet you. Stephanie's told me that she's been talking with you about how you've been managing at home, doing your day-to-day activities. And I wanted to let you know that those questions are questions that we actually ask all of our patients because it helps us plan for your safety both here in the hospital as well as when you are ready to leave the hospital. So I just wanted to let you know that it's a very common, these are very common questions. And I know that you've been talking to Stephanie about how things have been going for you at home, how you've been managing with your day-to-day activities. And I wanted to be a part of that discussion because part of my role here in the hospital actually is to work with your medical team, the nurses and doctors and therapists, to help plan to keep you safe here in the hospital, as well as to help plan for things when you're ready to leave the hospital. Have you been able to talk to anybody from your family since you've been here?
No, I haven't talked to my daughter. Her name is Ruth. I understand you left a message for her.
Right. I actually did leave a message for her about an hour ago and just got her answering machine. And so I will definitely let you know when she calls back. I know that earlier you were talking to Stephanie about how you did your shopping, especially for groceries. Why don't you describe for us what a typical meal is? I know where you get your food, but what is it that you normally eat, let's say, for dinner?
Usually a sandwich with cheese and luncheon meat and sometimes soup, and sometimes I'll fix a microwave dinner.
Okay. Do you ever use the stove or oven?
No, I use the microwave.
Okay. Has it been a long time since you've actually done that kind of cooking?
Yes.
Okay. Is it because you don't enjoy that kind of food, or is it difficult to?
It's difficult to do because of my legs swelling, and standing for any length of time is hard.
Okay, I understand. What about things like cleaning your house? Most specifically, heavy chores like vacuuming or mopping the floors.
Well, I live alone, and I don't make much of a mess.
What about periodically, once every few months, to do a big clean? Do you do that, or do you get someone to come in and help?
My daughter usually helps with that.
Okay.
She visits every month or two.
All right, good. Now moving on to laundry. Do you have laundry facilities that are close by, and do you do your own laundry?
I haven't done it in quite a while. I
Okay,
just haven't felt up to it.
sure. And if you decided you were going to do it, would you be able to do it without help, or does someone come and help you?
I think my daughter would help, or possibly my neighbor might.
Okay. What else does your neighbor help you with?
He helps with heavy lifting and sometimes with errands, and as I said, sometimes he brings me food.
Okay. Is he someone that you can rely on and that you have an arrangement that he'll get you food, or is it kind of hit or miss?
No, it's just from time to time when I need help, but it's not a regular schedule.
Okay. So Stephanie told me that when you need to get food, you go down the street to a local 7-Eleven, and that's primarily where you get your food. What if you need to go a further distance? Let's say you needed to go to a doctor's appointment or a dentist appointment. How would you get there?
Well, I don't drive. My husband did all the driving, so I would probably ask for help, maybe ask my daughter to take me if I had to go that far away.
Okay. Do you ever take any form of public transportation, like the bus or cab?
I can take the bus, but I still have the problem with pain. It's hard to use because of my problems with my legs.
Okay. And about the last time you were able to take public transportation?
At least a month or two.
Okay. You're doing great. We're almost done. Now let's move on to your medications. We know from your doctors that you've been on several different types of medications for primarily for your heart failure. Can you tell us how you get your prescriptions filled? Can you get to a pharmacy, and then once you get your medications, can you read the labels and take the medications on your own?
Well, I think I need some help with this. I'm a little confused, and I can't remember how to take them sometimes, and I can't remember when I've seen the doctor. Can you help me with this?
Definitely. That's something that we here in the hospital can help get you on a good medication plan. And I also think that it would be really important to involve your family with that. So when Ruth does call us back, I'm hoping that she'll be free enough to, I know she lives about 2 hours away, I'm hoping that she'll be able to come to the hospital, both to support you and then also to meet with us and meet with the social worker and case manager so that we can plan for some of this. So you're doing great, and we only have one more question. And that question is around your finances. Do you pay your own bills, things like rent and electricity, and do your own banking?
I use the same bank I've used for at least 10 years, and I write checks for my bills.
Okay, so right now you don't think you're having any trouble with any of that?
I don't think so.
Okay. Well, those are all of our questions. And now that we've been talking for a few minutes about the day-to-day activities, I'm wondering if this is, if our talking about it has actually made you think that you might need help with things.
Well, I still think I can take care of myself and that I want to go home, but I'm willing to listen to alternatives.
Okay. Well, I think that when we reach your daughter, Ruth, I'm hoping that she'll be able to come and meet with us. And I think that we have some time. Today's only your first day in the hospital, and you'll probably be here for a couple of days so that we can get your heart failure medications managed and just make sure that a physical therapist sees you. Because you've been having the fatigue and the swollen legs. So we want to make sure that your mobility and your being able to manage things like bathing and transferring are okay before we would let you go home. So probably will take a couple of days. We also want to, Stephanie and the other nurses here will be doing some education with you about the right foods for heart failure, those kinds of things. So we'll be back. You did a great job, and the information you've given us has been very, very helpful. So I hope we didn't wear you out too much. And I definitely will come back after I've reached your daughter and give you an update on what's happening. Let's talk about what we found after our assessment of Mrs. Johnson. We used the Lawton Instrumental Activities of Daily Living scale to assess her ability to manage her IADLs independently at home. And what I'd like to do, especially because we have Deanna and Josh here with us today, I'd like to be able to have all of us look at how we all scored and make sure we came up with the same score for our assessment. And then what we need to do is talk about what are we going to do with that information. We need to make a plan of care for her throughout the hospital stay, as well as how do we start planning for discharge. So I'll start. Why don't we talk about how she did using the telephone. What do you think?
Well, she answers the telephone.
Okay.
She specifically said that she communicates with her children via the phone.
Okay.
But as far as dialing, she definitely doesn't demonstrate independence with dialing phone numbers.
So you scored her as a
1.
Okay. That's how I scored her. Stephanie? Deanna?
Same.
Okay.
Same.
I scored it 1.
Answers telephone but does not dial.
Okay. And moving on to shopping. What do you think, Stephanie? How did you rank her?
I scored her 0 because she shops independently for small purchases only.
Okay. And what did she say about a bigger shop?
She just goes to one store.
Okay.
Yeah.
Any disagreement with that? You all scored 0? Okay. Food preparation. Deanna?
I scored her a 0. Heats and serves prepared meals or prepares meals but doesn't maintain an adequate diet. Just judging by the fact that she shops only at the 7-Eleven, there's a limited collection of things that she can choose from, plus she stated that she eats frozen meals and sandwiches, which doesn't sound very well-rounded.
Okay. Everyone agree?
Mm-hmm.
Okay. Housekeeping. I scored her a 1 on housekeeping because she did identify that she can, if she needs to, do light daily tasks such as dishwashing and bed making, but that she has not been able for some time to do heavier housework like mopping the floor or doing vacuuming or things like moving furniture around the house. Did you all come up with the same answer?
Yes.
Okay. Laundry, Josh?
She didn't demonstrate any independence with that. She specifically said that that she did not perform those tasks independently.
And she had a neighbor or her daughter
Yes.
be responsible for all of her
So I
laundry.
scored her a 0.
Okay, great. Stephanie, what about her mode of transportation? How does she get around to appointments and things?
She actually calls her daughter, so I scored her 0, like travel limited to taxi or automobile with assistance of another.
Okay.
Right.
And then responsibility for own medications. What do you think, Deanna?
Well, she stated that she's confused about the medications. She also stated that she doesn't easily have access to the pharmacy based on transportation and other things. So I scored her a 0, is not capable of dispensing her own.
Right, and that kind of amazingly was the only thing that she identified that she
Right.
needed help with.
Right.
So at least she recognized that she was not doing a good job with that. So I'm thinking that might make it a little bit easier for us to put some things in place because it's the one thing that she's identified to all of us that she needs help with.
Right.
Anyone disagree with that? Okay, so the last of the IDLs is ability to handle finances. And just between us, I didn't know how to score her because she said everything was okay. But we actually don't have any evidence to the contrary. And in this case, I gave her a 1 on it because she said things were okay, but I also had a mental note to myself that this is something that I need to involve her family in. So this would be a time that I would ask her daughter, who's going to be possibly staying at her apartment tonight, to look around and make sure that she's been bill paying, maybe talk to her apartment manager and just see if there's any issues with that. Because I would think that she may be having some of those same issues with finances that she's having with some of these other IDLs. So overall then, I came up with a score, if we need to score it, 2 to 3 out of 8. Mrs. Johnson actually did identify that she had a lot of deficits. What I see is that even though I think she told us fairly truthfully what she's doing, there's a disconnect about her health overall. I think earlier on at the beginning of our discussion, Stephanie was talking about wanting to have nursing look at her ability to do her ADLs. First, we know that there are many deficits in her IADLs at this point,
Right.
and just being able to identify that she is as independent in doing her ADLs, so things like feeding and bathing and doing her grooming and being able to transfer like out of bed and walk around to her apartment. So we definitely want to validate that. And it's a little bit easier to do in the hospital because those are things that we can actually observe. The IDLs, unfortunately, we use a self-report and then try and get information from other informants who actually might know the patient, and then make our final assessment from there. So we will need PT and OT to help with that. Definitely nursing is going to need to put a plan in place for teaching, so patient and likely family education about heart failure, medications, diet, activity. And then we need to actually meet with Ruth, her daughter, and see what are the options for her mother at discharge.
And I'm just interested if you could clarify how much more or less independent might a person be based on IADLs versus ADLs?
That's a really good question, Deanna. Actually, the IADLs are thought to be higher level functioning because there's a big cognitive piece to the IADLs. So things like using the telephone, managing finances, and ability to manage your own medications and arrange transportation are much higher order function than the ability to feed oneself. Preparing the food is higher order than actually being able to do the actual feeding. So in terms of comparing the two, they're different. They're different areas of function. And how does one impact the other? Generally, if one, and if you think about it, it would make sense if one doesn't have access to food or doesn't actually know how to use a stove, their ability to have good nutrition and maybe even ultimately feed themselves could be impacted by that. So you would need to have fairly good IADL function. And if you don't, that could ultimately impact your ADLs. A lot of people, though, and Mrs. Johnson may have been a good example of this, she may have some cognitive issues going on, and they've been going on slowly over a longer period of time. Because she's lived in the same apartment for 30 years and is very local in her neighborhood, many of her neighbors are long-term neighbors, and she goes to the same store and probably does go to the same bank. She may be actually able by routine to keep functioning as much as possible in the community, and only now that she's had a heart failure exacerbation and is medically ill and needs to be in the hospital that some of these things are coming to light. So many patients exist in that really fragile state in their community independently for as long as possible, and then something tips them over. And in this case, it's her heart failure exacerbation. So I think our next step then, Stephanie, would be that you're going to write this up as her plan of care. And then we will be having our interdisciplinary meeting with the team a little bit later. I do want to let you know that I have spoken over the phone with her daughter, Ruth, and Ruth is on her way to the hospital, and what her plan is actually is to come see her mom, make sure that she's okay, and then she's actually going to go spend the night at her apartment. Some of the things that I've asked her to look for would be evidence that her mom has been clean and able to do her hygiene at home. She will look for evidence of whether she's been paying her bills. She might actually stop into the apartment manager, who actually is Mrs. Johnson's next door neighbor, and find out if her mom's been paying bills on time, that kind of thing. So she will be our informant as to how she's really been doing, and will validate Mrs. Johnson's self-report.
So the first thing that would be necessary would be to have the physician order both a physical therapy and an occupational therapy evaluation, and then we can certainly perform those this afternoon in order to evaluate her mobility. As far as physical therapy goes, her mobility to guarantee that she's safe enough to be able to return home at some point. Also, with her heart failure, it will be important to assess her activity tolerance, so assessing vitals with activity, heart rate, blood pressure, oxygen saturation, all of those things to make sure she's not having oxygen desaturation with activity, which could lead to some confusion.
Okay, perfect. Because so far, I don't think she's gotten out of bed yet, and she is on 2 liters of oxygen.
And I think from, excuse me, from an occupational therapy standpoint, we'll be evaluating her self-care and really seeing what she's able to do, but also seeing what her activity tolerance is for that, and look at if she can incorporate some energy conservation techniques, if she's able to do that with some of those activities of daily living. Also, I can evaluate how she does with some basic IADLs in the kitchen, a little bit of kitchen mobility, using the microwave, see if she carries through with that, and just do a quick assessment and see if she can incorporate some strategies for learning to see if that is safe as well.
So that's great. When would that be done? Would that be when she's very close to time of discharge that you would do that with her?
Well, I think we'll do the basic assessment today of her activities of daily living, her tolerance, her overall endurance, and then we'll see if she can handle the basic activities of daily living. Then maybe tomorrow or the next day as she gets closer to discharge.
Yeah, we'll certainly need to assess if she's going to need any adaptive equipment at home or an adaptive device for ambulation as well. And also, as far as her oxygen saturations, if she's going to need home oxygen as well. So those will be things we can help assess as well.
I think that will be teased out in the next couple of days. The physicians are still changing around her heart failure medications a little bit, and our goal would be to get her up and moving and try and wean her off oxygen, but that's still yet to be seen how that goes. Right. I mean, I'm hopeful that we can, over the next couple of days, convince her to go home with her daughter, even if it's just for the short term. And having spoken to Ruth, that's what she would like to see as well.
This just really looks like it's going to be a very specific plan for this patient. Is that typical? Is that part of why the IADL is used?
Yes, I mean, we do IADLs on every patient because we do want to identify as close to admission what the deficits are, so that we have time to sit together like we're doing today and make a plan. If we don't ask those questions, we won't know that she's been failing at home. We would be sending her right back out for her to not be able to take her medicines and to continue to eat the wrong foods, and it would just lead to her being in the hospital again shortly. So in answer to your question, yes, we use this information from screening instruments like the Lawton IDL in order to build our plan of care. Stephanie, as part of the nursing care plan, is going to incorporate the healthy heart teaching, and we'll be starting to work with her on her new medications or changes in her medications. if Stephanie or the other nurses here identify that she still isn't really learning about her diet restrictions, we may actually ask a nutritionist to come in and help with that. And then I think ongoing assessment as we kind of go day by day and see how she's progressing, we can identify actually the locale that she'll be discharged to as we get a little bit closer and see how she is with her daughter. Great, so we'll just keep in touch on how things are going.
Alrighty.
All right, thanks so much.
Thanks.
Thank you.
The CATS activities of daily living and the Lawton instrumental activities of daily living are two functional assessment instruments. When we think about function, we often think of three different domains: activities of daily living, instrumental activities of daily living, and mobility. So you can't really assess one and not the others because they all really are very interconnected. The difference is, though, that the Iadl assessment really assesses higher level functioning. There's a cognitive piece to that. Also, the Lawton, because it does have higher order functioning, it may be a little more sensitive to earlier disability than the ADLs. We like to sometimes think that as we've gained those abilities to do those tasks like feeding and dressing and grooming, all the way up to managing finances independently, that if we begin to lose the ability to do that, we actually lose them in reverse order. So we often think that the first disability we'll see will be in managing finances and managing the ability to successfully take medications. If we're looking to do both a CATS ADL assessment and a Lawton IDL assessment, it doesn't really matter which assessment is done first. Logically, I think in the hospital we start with the ADL assessment because it's the most basic, and we also have the opportunity in many settings to be able to observe the patient doing it. So in a hospital, a patient would be able to demonstrate that they can transfer from the bed, let's say, to the bedside commode, that they can actually do their own grooming. Even though patients don't wear their own clothes in the hospital, we can actually have them put on a gown. It's not that difficult to have them get dressed, or at least be able to put on shoes and socks to demonstrate that. We certainly see patients feeding themselves, so that's much more straightforward. The Lawton, the IDL, is not, it's impossible really to assess that in the hospital. So the instrument was actually designed to be a self-report. So you can either give the actual assessment to the patient and have them fill it out, or what's often done is that a nurse or physical therapist or occupational therapist actually sits down with the patient and goes through those domains one at a time. And I think that's probably the best way if one has time to do that, because as I mentioned before, it's easier to kind of tease out if there's some questions if you actually are sitting there and talking to the patient and maybe asking subsequent follow-up questions for clarification. Trying to get a handle on how many people in the United States have IADL disability is very difficult. First of all, there's almost 2 million people that live in nursing homes, and it's really unknown for all those people if it was an IADL disability that necessitated their going into a nursing home. Some fairly recent statistics show that about 10% of people between the age of 65 and 74 may have some type of IADL disability, and then almost 27% 75 and older. The difficulty with trying to determine how many people have disability is that it's really been defined in different ways. There's about 200 assessment instruments that measure function, and we all don't use the same instrument. Just even in terms of language, we don't use the same language. We might say function, functional status, functional ability, handicap, disability. So depending on who's looking at these patients or these people and what they're using as a description has really confounded the ability for us to get our hands on how many people really are disabled. you can't discharge someone without knowing what their home situation is like and whether they can successfully manage to get their prescription filled. They can get back to the doctor for their follow-up visit. These days we send patients home after a very short length of stay. They're very sick, they have multiple comorbidities, and we send them home on very, very complicated discharge plans. And we've got to know that they can actually keep up with that discharge plan before we let them go. In the hospital, it's really important to do that assessment as close to admission as possible so that it gives us the opportunity to do some planning. Whether one uses the Lawton as the instrument that we're talking about today, possibly not everyone uses that, but they use something like that because we're both mandated by regulatory agencies to be able to capture that information to begin discharge planning on admission when we're talking about acute care. So my recommendation, and I think recommendation in the literature, would be that everyone in a hospital has an assessment, and then in the community, when one sees their primary care provider, there should be some questions about instrumental activities of daily living. And then certainly if someone has been in the hospital and then going back to the community, that if they have a home health assessment, PT, OT, or nursing would do that over time post-discharge. Another important area that I think should be where the assessment should be done would be in the emergency department. So not every person who comes into the emergency department gets admitted to the hospital. And that's really a very opportune time for nursing or rehab to do an Iadl assessment before they discharge them to home so that they're not right back in the hospital again because no one's asked the questions. I think the biggest challenge may be what the outcome of an assessment like this may represent to a person. And even patients that are fairly impaired cognitively on many levels understand what being in the hospital might mean to their independence. And then especially when a stranger, even though it may be a nurse, goes in to ask these questions, it can be very difficult to want to give honest answers. So I think being able to intuitively maybe understand or kind of weigh their answers, and is it congruent with how they presented to the hospital, were they groomed, are there issues with their ADLs that may give you some clues that there may be some trouble with their IDLs at home. That's kind of a first place to start. And then what do you do if someone says, everything is fine? And that actually is something that I hear very commonly. I kind of get shooed away or poo-pooed that everything is really doing well and they have a daughter or son who's local who can help if they need it. And they prefer to go home and they don't believe they need any kind of rehab. And that's it. That's the end of the discussion.
I want to go home.
There's many ways to get around that. The most successful way that I found is actually to establish rapport with the patient and work with them. Maybe it might take 3 days, and you may be actually getting the assessment and making your discharge plan closer to discharge than you would like. But you have to have the person trust you, and that doesn't happen in a few seconds. So being able to work with them over time, I try and see them every day, make sure I do a check-in. Sometimes I see them a couple of times a day. And once that rapport is established, really spend time telling them how important this is, that it's for safety, and that really our number one goal is that we get the patient to the place that they want to go. So if it's home, if it's with their family, whatever the discharge goal is of the patient, that's where we start. And then, try and convince them that by getting honest answers to the questions that we can put things in place so that they actually can get home and be as independent as possible. To interpret the Lawton Iadl, actually I think it takes more skill than actually administering it, because it's not as straightforward as it would seem. It's not just that a person can or can't do something, but what's the meaning of that? Are there other things that are going on? If someone has major depression going on, and that's not uncommon in an older very medically ill, chronically ill person, they may not be doing some of these IDLs because of their depression, and they just actually can't get enough oomph up to go to the store or to do their laundry. So I think this is a great screening tool that can be used by nursing or rehab to kind of get the first line assessment of a really targeted what's going on with these really important domains of function, but oftentimes it requires ongoing assessment. So a person may need a psychological assessment for depression. They either need to see a psychologist or a psychiatrist. It may be that a person can't do the IDLs because of physical reasons. So having the healthcare team, medical team, nurses, rehab, come in and kind of get them back on their feet from a rehab perspective. In order to prepare the patient for the IDL assessment, I think it's important to explain to them what you're doing. I think it's really important that they think that it's not just an assessment that you're doing of them, but it's actually an assessment that all patients who come into the hospital are having. That it's for safety reasons, it's for discharge planning, it's for making sure that everything is okay in the community, and that's where we get started in terms of planning for discharge, and that we're not just singling them out as an older person because we think they can't do it. And actually, it's a time to celebrate what they can do. So I think it's important not just to focus on all the negative things, I can't use the telephone, I can't go shopping, but it's also a way to be able to identify what their strengths are, and that's how we start to build. So I try and, kind of keep my focus on the positive instead of on the negative. I think it's important if families are involved in the day-to-day care of their loved one who's in the hospital to have them included as in the assessment. I mean, certainly you would want to ask the patient if it's okay if their family is there, but I think, explaining to the family the same way that we do with the patient what the purpose of our assessment is, that it's really to help target and identify any areas to try and keep their loved one as independent as possible for as long as possible.